Welcome into another edition of Baton Rouge Ortho Talk. Very pleased to be joined today by Dr. Wame Waggenspack. We're going to get to talk a lot of elbows and arms and really gnarly stuff too today. It's great to have you. How are you?
I'm great. Thanks, Matt. Appreciate you having me.
Of course. We've gotten to know a lot of the BROC docs through this series, which has been an awful lot of fun. So if you would, kind of give me the Cliff's Notes version of you.
Sure. So I grew up in Baton Rouge, grew up in Magnolia Woods subdivision. I always joked that I was kind of an honorary Kenilworth subdivision grad too, because a lot of my friends were there. So went to St. Aloysius for elementary school, went to Catholic High, graduated in 93. So I just had my 30-year anniversary, I guess, of graduating. Doesn't seem like that long ago. And went to LSU. I actually did mechanical engineering undergraduate and decided somewhere around my senior year that I wanted to be a doctor. I didn't have there were no medical people in my family. My original thought was to go and do biomedical engineering after I graduated, and I just kind of gravitated towards medicine, and then, here I am in orthopedics.
Did something happen that, because normally if you're in some form of engineering, that's always been like a vision, like that's always clicked for you.
Sure.
Right? So to make that transition feels pretty drastic. Did something happen?
I can't say any one thing in particular. Just, I will tell you this. My mom always wanted me to be a doctor, and look, when you have parents like my awesome parents, you always want to make sure they're happy. And so that was always in the back of my mind, I guess. And, I was working in a biomechanics lab with one of my professors, and I just found the medical side of it more fascinating, I guess, than I thought. And frankly, I think you get to the end of college and you realize, well, maybe it's not that hard to go through and do a little more schooling, So maybe it was a little bit of laziness at first to avoid it, but I'm happy where I am now. It was a circuitous path to get there for sure. So I ended up having to do a fifth year and had to retake all the things I had tested out of. So that was an interesting time. Fifth year LSU student taking freshman biology. I think I corrupted a lot of freshmen that year, but that's okay. So
I took freshman biology like 4 times before I finally made a D just to pass, so I could move on with my broadcast career. But wait, so did you finish undergrad in mechanical engineering?
I did. I finished undergrad in mechanical engineering and then went to med school.
And went to LSU med school as well.
LSU med school. Then I even had a weird circuitous path to get to orthopedics. So I was trying to decide between orthopedics and emergency medicine, and again, I didn't really have anybody in my family to kind of go to, and frankly, I probably didn't take advantage of the things I should have at the time, and so I ended up doing emergency medicine. The whole time I was there, it never really felt completely right. I always enjoyed doing orthopedics in the ER. And I almost switched my second year, but it was a 3-year program, and I was almost done. So I said, well, let me just stick with what I'm doing. Did a primary care sports fellowship in California for a year, and was out in practice. So I went to Bienville Orthopedics in Mississippi. I was there for about 20 to 24 months or so. And what I found is I really hated giving away the surgical cases. I really enjoyed making a rapport with the patients, and I kind of gravitated away from emergency medicine at that point. So I started working at LSU in the ER and in their orthopedics department as a primary care sports doctor. So I would see clinic and just do the non-surgical orthopedics. And I finally, I have a very loving and understanding wife, and she saw I was miserable. And 4 years into this, after I was done, I went and talked to our department chairman, Andy King, who I owe my career to that guy. He not only did he not hesitate, he really fully supported me and helped me get a spot, because if anybody that's gone through residency in med school knows that it is almost impossible to get a spot to do a second residency, because residency is, it's a grind, and residency directors, all they really want is to make sure they hire the right residents to kind of get through the program and don't have to fight, people dropping out and those kind of things. And when, if you don't know me from Adam, you may think, well, when the going gets tough, your second year is when you're taking a lot of trauma calling. It's just the hours are just brutal. Well, he has an out, so he can easily just say, you know what, that's enough, I give up. But Andy Annie King really knew who I was as a person and knew how driven I was to do this. And I think once, most people meet me, they would agree with that. When I find something that I want, I go for it. So I was able to go back and do a second residency. I had to start all over again.
Wow.
So I ended up doing 5 years of orthopedic surgery. And one of the things that drew me to doing orthopedic surgery from where I was in the first place was shoulders. I loved throwing injuries, and baseball's been my favorite sport since I was a kid. Not that I was any good at it, but I've loved it. My friends and I, we used to watch Harry Carey, and I was a Cubs fan because of WGN. There was
Ryan Sandberg?
yeah, Rhino Sandberg,
Flip Shades,
yeah,
Mark
Flip
Grace.
Shades, Mark Grace. The whole Ron Say the Penguin, third
Yeah.
base. Those days, and so anyway, I was just kind of drawn to shoulders, and that's kind of how I ended up specializing in shoulder surgery and shoulder reconstruction. And so I tell residents and med students that I work with that are going into orthopedics that come and shadow me or work with me, find something you enjoy reading about and learning about, because it's really a lifelong learning thing. I mean, Rick, I know you did his podcast recently, and he and I do clinic right next to each other, and he and I are constantly talking about how I always review the anatomy constantly. My cases the night before, I review the MRIs, and I enjoy doing that because I want to be a perfectionist about it. And if you find something like that you're that passionate about, it's hard to ignore that, So that's how I kind of ended up where I am. But I did 10 years of postgraduate training after I finished med school, so I'm probably the most overtrained orthopedic surgeon in the country.
Rick, of course, is Dr. Rick Ahmed, who we had on the show, and he was a fascinating guy to talk to. So just to make sure I have this right, so you graduated med school, you did your residency in emergency medicine. You were practicing.
I was practicing.
A practicing
when I went back.
Emergency medicine doctor, realized you didn't like it, went back and did a second residency in orthopedics, and had to basically hit the reset button on your career.
I hit the reset button, including
How old were you?
intern year. I was 35, so I graduated residency right before I turned 40, much to the chagrin of a lot of my residency classmates who wanted to harass me about turning 40 as a resident. But I didn't finish. I finished and started practice at 40, right before I turned 41.
It's a great lesson, though, I think, no matter whoever might find us for different reasons. It's a great lesson for anybody in life to say, even at 35, you feel like you're deep into your career and there's no turning back. You're still super young.
For sure. Oh, absolutely. And it's interesting because it's not a completely unique story. And one of the things that was comforting along the way is that I met other people and they would say, yeah, man, I had a guy that did that exact same thing, not necessarily ER to ortho, but just did a second residency, realized they weren't happy and that kind of thing. So it happens. I feel extremely fortunate and blessed to be able to do it. I mean, I know that sounds weird because I went back and did 6 more years of intense training. And I mean, look, it was hard on my wife and hard on my family. I owe all of them a huge debt. My parents, were both in good health, and they live in Baton Rouge. So even while we were in New Orleans, they constantly came down to help because my wife was having to work. I mean, I took an 85% pay cut my first year residency, and it was tough. But now it's interesting because now I can't imagine doing anything else. And I've been out. This is my 8th year in practice, but I can't imagine doing anything different than what I do.
What a great story.
So. Yeah, I appreciate you saying that. I mean, it was more just a matter of, I think, finding my path in life. But I agree with you. I think, even at 35, you feel like you're kind of set in. It's just not the case.
So many people struggle professionally with patience. We see that in media a lot.
Yeah.
It feels like it's hard to get your wheels turning.
Yeah.
And so once you gain some traction, you never want to lose control of that, even if you're not liking what you're doing.
For sure.
So that's a pretty fascinating. Hopefully, a lot of people may hear that and be encouraged by that. I'm curious. Do you feel like? Because I would imagine when you were doing emergency medicine, you probably dealt with a lot of trauma as well. Do you feel like that your emergency medicine training has helped? Because we've talked to some doctors who, in some orthopedics, who might have done different rotations in emergency medicine, and they've said that emergency medicine rotation may have helped in ortho. Have you found some similarities where your time as an ER doc helped you?
I think overall it made me a tremendously better physician. Overall, I think, I have an interesting perspective, I think, because I've been on both sides of it. And, one of the things we always tell med students when they're trying to decide what they want to do is to first choose whether you want to do medical specialty or surgical specialty, because they really are two very different. It's different mindset, it's different field, and I've been on both sides of it, so I think I have an interesting perspective on that. And I think overall it made me a better physician, and I think honestly it's made me a better orthopedic surgeon, because before I went back and did surgery, I really had to rely on my physical exam much more, and I really had to know the anatomy down cold. When you do surgery, you kind of get an inside look, not to be graphic, but I mean, you get an inside look at the body, so the anatomy makes sense a little more. And I had to read a lot more and study a lot more, and so I feel like it helped me. I feel like it's helped me be a better clinician overall.
When why ultimately did you choose BROC, or what led you to BROC?
I was from Baton Rouge, and so it's interesting because even though I'm from Baton Rouge and I'm back here now, with all this training I did, after I left LSU, I didn't live in town for 20 some odd years.
You said California, Mississippi?
Yeah, I did my emergency medicine training in Parkland and Dallas. So you'll notice a trend of like giant trauma centers.
Sure.
I don't know why I'm attracted to that, but hey, why
Isn't
not?
Parkland the JFK hospital?
That's the JFK hospital.
Yeah.
So it's also, if it's not the busiest ER in the country, it's probably top 2 or 3. I don't know. The numbers probably fluctuate, but an incredibly busy ER program.
I'm sorry to interrupt, but is there I've never been. Yeah. Is there some sort of dedicated area?
There's a little
So
plaque.
after President Kennedy was shot, he was brought to Parkland.
Right, correct. Interesting, while I was there was still somebody working there that had been like a resident or something on call that day. So
wow.
Kind of interesting. Yeah, obviously it's they actually redid Parkland, so they've knocked down that building. So I don't know what they ended up doing with that. But while I was there was a plaque, right where they worked on him. But it wasn't still part of the emergency department.
Sure.
So. But
I would hope there would be some advances from the 1960s
you would hope
in emergency medicine.
For sure. So we went Dallas, California, Mississippi, New Orleans, Houston. That was my circuitous route, and then back to Baton Rouge. So, when you do residency in New Orleans, we come up here to do our rotations. We used to do it at the old OK Long, and now it's at LSU's clinic right on Perkins there, and we're doing work at Our Lady of the Lake. So you always work with the BROC guys. They were always there to help us when we needed help, and they just had a great reputation. There's a lot of people that graduated from LSU's residency in our group. So there's kind of this natural symbiosis, I think, and so I think it works out beneficially for both parties, because they get to see the residents that they like and are good, and kind of focus on them and say, hey, you're interested. So I got asked if I was interested to join. I definitely there was some mutual interest there. And it just, it worked out that way. So,
and every orthopedist, as I've learned, at some point during your training, you have to choose a subspecialty.
You do.
So you mentioned baseball as one of the reasons you were always interested in arm care. Did you always know that that's what you were going to do, was shoulders, elbows initially?
I was trying to decide between sports, doing a true sports medicine fellowship and then doing a shoulder elbow fellowship. So they're a little bit different. The shoulder elbow fellowships around the country mostly focus on shoulder reconstruction, like replacements and those kind of things, more than you may get in a sports fellowship. In a sports fellowship, you may do some shoulder replacements, but it's not as big a part of your practice. The sports fellowships also deal with a lot of knees, ankles, hips. It just depends on where you go. Every one of them is a little bit different. There's some standardization of what you need, but every place you go and train has a different, kind of feel to it or focus to it. So I ended up ultimately feeling as if I got pretty good sports training. I was primary care sports trained, so I really had a good feel for that. And then we did a lot of knee surgery in residency, and I felt comfortable with the basic stuff that I thought I would be doing. And I was just drawn to the shoulder, and that's what kind of led me down that path. I also, obviously, with my engineering background, biomechanics is interesting to me, and I think the shoulder is just a fascinating joint. It's the most complex joint in the body, from my perspective, from a motion standpoint and a balance standpoint. And there's a lot of biomechanics involved in shoulder replacement. So all that kind of drew me there, and that's how I ultimately made the decision. I knew fairly early on that that's what I wanted to do. That was kind of my, I think you're supposed to decide somewhere in your third year, which is halfway through your residency. I think I knew by early in my third year, if not earlier than that.
From my perspective as a guy whose career is primarily focused around sports and sports media, when I think of shoulder injuries, it's baseball, right? It's baseball, or if football injuries where guys are maybe leading with the shoulder and have issues there. In everyday regular life, that's not high intense athletes. What are the most common shoulder issues that you see?
It really depends on the age group, and so I have two awesome mid levels that help me out in clinic, and so one of the things I've taught them as I've trained them to be able to evaluate things is just think of it in age ranges. So, if a teenager comes to me with shoulder pain, it's almost always, if it's a structural injury, it's almost always a labral injury. So labrum is labral tear is what you'll get with a dislocation. So the labrum, I tell patients, it's like a rubber O-ring around the socket of your shoulder. And your shoulder is a very interesting joint because you've got the most fluid motion in the body, right? So you can put your arm above your head, behind your back, go all over the place. You really can't do that with any other joint. And the reason you can do that is because the shoulder is like a golf ball on a tiny tee. So the socket is really relatively small compared to the size of the ball of the shoulder. The labrum deepens the socket, so it's like a rubber O-ring or a gasket there. And so if you tear that when you dislocate, then it makes your shoulder unstable. So teenagers, by far the most common thing I'll see is some sort of like labral injury. If they have a true structural injury, like they had a dislocation event or something like that. Probably the second most common is a contact injury that'll cause like an AC sprain or something like that, from football, landing on your shoulder.
Yeah, fall. You fell off playground.
Exactly. Middle school, you're usually looking at more growth plate injuries, so you can get something called Little League shoulder, which is essentially just a stress injury to the growth plate of the shoulder that just needs rest. So as you get into 20s, 30s, it's still mostly labrum, but it's more of the, hey, I've been working out and now my shoulder's hurting me. And so you start getting what's called slap tears or bicep pathology. So one of your bicep tendons goes into your joint. It's basically like a rope running on a groove and goes into your shoulder joint deep. And where it attaches is called a superior labrum. And a tear of that area is called a slap tear, just because it's hard to say superior labrum, anterior posterior tear.
Right.
We're simple in orthopedics.
Way easier.
We like to abbreviate things. So I'll start seeing those kind of complaints in guys in their late 20s or 30s. And it's usually the ones that are still working out in the gym or they're working out in the yard a lot. And it'll just be this kind of, hey, my shoulder's been bothering me. It's nagging me. It's not enough to where I can't do what I want to do, but it doesn't feel good anymore, As you get into your, 40s, 50s, those kind of things, it starts being a mix and less labral and slap tears and more rotator cuff. And so when you get into your 50s, 60s, it's more rotator cuff pathology, whether it's an acute injury or it can be just a general wear and tear. Arthritis is in the mix there. It's not as symptomatic in most people as until you get into really severe arthritis. So that's usually your 60s, 70s, that kind of thing.
Do you, especially whenever you're talking about younger people that may have an injury, let's say you have an injury around teen years, it's never treated surgically or anything like that. You just rest it and it goes away. But then later in life, you have issues. You're smiling. You see this a lot where there are issues that recur. I deal with that, right? I had a baseball injury, shoulder soreness, whatever. Now, if I go throw a baseball, it is like fire in my shoulder. So for someone like me or someone who maybe had injuries as a younger age where some of those symptoms persist, what's the cause of that?
So, Generally speaking, if you have a kind of nagging injury from high school, it usually is some sort of labral injury. And a lot of times what happens is it won't be enough to where it affects you once you stop. If you stop playing sports, or you're just not you're just not doing as much competitive stuff as before, usually people will just kind of self-limit and say, you know what, I can do this exercise at the gym, or I'll just stop, or I just won't throw the ball as much,
Right.
And then once they start having kids and they want to throw the ball with their son, that's when I'll see it back. But generally speaking, what it is you probably had a little labral damage or injury or something like that, and it just wasn't enough to make you dysfunctional. And then once you start throwing is a very hard thing on your shoulder. So, it really takes a structurally sound shoulder to do. And it can be as simple as you have a little fraying of your rotator cuff, or you have a little fraying of your labrum. It doesn't necessarily need to have this big tear that's floating around,
Yeah.
So it can be just as simple as that. But that, I will tell you, that is a very, you said I was smiling, it's true. I see that literally all the time.
Yeah.
Like, hey, yeah, I had this nagging injury in high school, and it never completely went away, but it's not bothersome. The thing about labral tears is that your shoulder is functional, with the exception of teenagers that have instability and they dislocate. Generally speaking, slap tears or simple labral tears don't cause a lot of instability, and it'll just be this nagging thing that bothers you.
So what do you do about it?
It just depends on how symptomatic. I'm 47. I'll be 48 in a couple of months. So I see a lot of my classmates that are still working out and being active. And so I'll tell you what I tell them. If it's something that you can live with it. We usually start with simple stuff. Physical therapy, working on your scapular stabilizer muscles and your rotator cuff. And what that does is it strengthens your muscle and corrects your mechanics enough to usually it'll take pressure off whatever's bothering you. And that's enough. The next step is a little steroid medication just to settle it down if it's inflamed or hurting more. You can do biologic injections, and then it runs the gamut all the way up to surgery if it's bad enough. But I will tell you that's a rarity. Usually I can get you better without that.
When is shoulder surgery recommended?
When your pain and or your dysfunction just affect your quality of life and what you want to do enough to where you just don't feel like you can live with it.
I'm sure there's a lot of parents whose kids play baseball who have these concerns. Right? This is something, I know you're also team doctor for LSU softball. Now, that's a different throwing motion for pitchers, but the throwing motion overhand is still a real issue in softball or baseball, or I would imagine even in something like lacrosse, potentially, where a lot of kids are taking up lacrosse. You're going to see that a lot with that motion where it's very shoulder intensive. What do you tell parents? What do you recommend to parents arm care for their son or daughter that are playing those types of sports?
So, the data is really clear on this, that the most important thing beyond anything else is total workload, and that goes into pitch counts, throwing counts. Jimmy Andrews in Birmingham they've really done some amazing work with this over the years, and he's a fascinating guy too. Side note, if you ever get to meet him, just an extraordinary individual and very down to earth. But the total workload on your body in general, with any injury or any sport you play, whether you're injured or not, is truly important. And so I think what I find a lot of times is the kids that have problems are the ones that are really, really motivated and may have to work hard to get to the level they want to be at. And I don't know if that makes sense, but maybe just not the ones that may not be the natural athletes. I see more problems with overuse in the natural athletes once they get to college. We see that a lot. The freshmen, they get there and they hit the freshman workload, and it's ramped up quite a bit from where they were in high school. And you'll start to see a lot more overuse injuries there. The ones I see in high school are usually the kids that are super motivated and they're good, but they really have to work hard to get to that level that they want to be at. And I think sometimes they just, there's a little bit of a lack of recognition that you can overdo things, especially in a teenager. It's hard to not think you're bulletproof as a teenager. So, in general, even before they have an injury, I try to emphasize the importance of always working on your form, keeping a close eye on that. As a parent, you can watch your kid, you can watch them and know that something's not right far before I can, or even sometimes even the trainers or coaches. Stick with a good program for your core, your shoulder, your legs. Everything in the kinetic chain matters. For throwing injuries especially. I see a lot of elbow pain along with shoulder pain. Those are the two most common. But really, especially the elbow is just kind of the last conduit to let the ball go. Problems in the elbow start way up here, and so sometimes parents and kids look at me funny when I start asking them to, checking out their core, and I'm checking out their shoulder, and they're, why are you looking at that? My elbow hurts. But really, the problem is here. The elbow just is the last one to see the stress. So I think the overall theme is to manage an appropriate workload for someone's age, and then just being able to be smart about it if you start having problems.
I know we've primarily focused on shoulder. It's interesting that you brought up elbow because most people are familiar with Tommy John, the UCL injury.
Yes.
At what point does that become common or a problem, or that you notice an issue might be arising there?
Well, it really used to be more of a problem when you get into the collegiate and professional level, and unfortunately, it's getting to be more and more of a problem. I know you're around sports, so you've seen the articles and you've seen the data. It's kind of unnerving how young kids are getting these injuries now, and we see a lot in high school now that you really just did not used to see back in the day. If I talk to my older, more experienced partners, obviously I've only been in practice 8 years, but the trend is that this is getting more and more and more common. And there's a lot of thoughts about what causes this, but in general, I think a lot of it is workload. There are exceptions to that. Everybody loves to use the Nolan Ryan exception, right? It's Nolan Ryan, I think, was one of those just aliens.
Yeah.
Not a true human. The guy's workload, if you look at it compared to everyone else around him, is just incredible. And how he was able to do that at his age is just it's a remarkable feat of humanity, I think. But again, I don't think you can compare somebody like that is the exception and say, well, if he was able to do it, then my son should be able to handle that same workload. Every kid is biomechanically different. And one of the things that's really interesting when I see patients, and the vast majority of the throwing athletes I see in clinic are high school, maybe some college, but it's really a lot of high school kids. And that's where you'll start seeing the problems now. They're getting up to the level where, again, they may have to struggle to get onto the team, and they're throwing more and training more and training more and training more, and they just overdo it. But there's some universal themes. It's that you have to work within your biomechanics and your biology. Everybody's different. And it doesn't mean, I tell parents, so for example, if I have a kid and I'm examining his shoulder, and some kids just they can externally rotate where you can almost take their hand and point it completely behind them, and other kids you get to about here and you can't get their arm any farther. So what happens with those kids, they're more at risk for having shoulder and elbow issues because they're going to get their arm in the slot they need to. So what do? They start using their scapular muscles, and it fatigues those muscles. So that kid may have to focus a lot more on his posterior chain strength than a kid that is just naturally flexible. But the kid that's naturally flexible may have some instability issues. So there's variations on every patient. And I really, what I do for them is kind of help tailor what they really need to focus on based on their anatomy and their biomechanics. And again, I know you can tell I love talking about this stuff because this just fascinates me because literally every kid is different. There's not a standard protocol that you can say, oh, this works for everybody. It just doesn't. So I tell them they need to find the workload that works for them, and they need to find the constellation of exercises and training and coaching and PT and all that fits within what they need to keep them functional.
We're didn't intend for this to be so baseball intensive, but or throwing sport intensive. But I think it relates to not only a lot of patients, but a lot of parents who wonder about this stuff with their children. Something else that's become, I don't want to call it common, but more prevalent is voluntary Tommy John, where we see kids in high school who are electing to have Tommy John because the thought is it'll make them stronger. Do you see that ever? Do you have a thought? Do you recommend that? Is there any science?
I have very strong opinion on that. It concerns me. The data does not support that thought process. If you really look critically at the data, the return to play at the same level or higher is about 85%, which is fantastic. But that means 15% don't. It is a extremely long recovery. It's a year plus. Most are saying 18 to 24 months now. We used to say a year, but I think we've realized that it's just too fast. You have to, for the most common technique, you take a tendon and your body has to turn it into a ligament. It's called ligamentization. So that just takes time. It's a long, arduous task to get back to throwing after not throwing for months. And there's constant setbacks. It's not, nobody goes straight up. It's like the stock market. It kind of goes up and then you have a little setback, you settle back down, go up again. And so I think there's a little bit of lackadaisical attitude towards Tommy John surgery. It's not the procedure itself. It's a fairly straightforward procedure technically to do. There's certainly some things that there's a lot of feel with it, but it's the rehab and the recovery. And to me, that kind of attitude towards Tommy John is just dangerous. I really do. I think it's dangerous. It's not a surefire thing.
I certainly appreciate the candor. I think a lot of people would need to hear that. You mentioned Dr. Andrews, Dr. James Andrews, who's a world-renowned orthopedist. He's also an LSU grad.
He's an LSU
and was an LSU track and field athlete during his time. Javelin or
I think he threw a javelin.
Pole vault.
I'm almost positive javelin. I may be wrong.
But it's interesting because you actually work with the LSU track and field team as well. What I would think track and field, most of what you would see would be soft tissue.
It is. It's almost all soft tissue.
So does an orthopedist deal with, maybe a dumb question, with soft tissue?
Sure. No, I mean, we deal with those as well. I will tell you, with my track and field work is really more about just helping the trainers and the therapists, and the chiropractor that help out the team. They do a fantastic job. Honestly, I'm almost there for a little bit of mental support for the athletes sometimes. It's there's a lot of mental fortitude that it takes to be a collegiate athlete that I don't know that the average fan understands. And I certainly didn't until I was doing this. I love baseball. I'm a terrible baseball player. I never could hit a curveball. My cousin, who was a month younger than me, knew that very well. And when we were playing on different teams, he could always strike me out. But, so I never really got to that level of sports. And so, I didn't really understand it fully either until I started doing what I do with LSU. And it takes a lot of mental toughness. Those athletes are very rarely feeling perfect and 100%, and they have to train through a lot. And so, my role with track and field, honestly, most of the time is just reassuring them, and we check things out a little bit farther if the athlete's struggling a little bit to get back to full go and that kind of thing. So, but it's almost all overuse soft tissue injuries, and it's frankly mostly the legs. The only ones I see with arm injuries are the javelin and the throwers.
Yeah.
So,
what's the most remarkable feat that you can remember seeing at a track and field event?
That's a good question.
Does someone or something come to mind immediately?
No, not really. I think the first time I ever watched pole vaulting, it was mind blowing to me how high that is. I'm not a heights guy. And you watch it on TV, you're like, oh yeah, sure. He just went 20 feet. Yeah, sure. Okay. And you see it when you're standing at the ground level. And it's
that's throwing him 20 feet in the air.
That gives you a whole new perspective. Like, wow, that is way up there, and you're hoping to land on a little small pad because it's not like it's soft ground around it. So that was pretty incredible the first time I watched it. So anyway.
We've talked a lot about young athletes and even non-athletes with shoulder or elbow injuries. As we've done this show, we've talked so much about joint replacements. Knees, hips, shoulders. Do you do shoulder replacements?
I do.
And what would cause someone to get to a point where they would look at or a shoulder replacement?
So shoulder replacement, I joke with my team all the time in clinic that I think when I get old enough, I think I'll just do shoulder replacement, because I will tell you that it's both from an academic standpoint and clinical standpoint, just one of the most satisfying things you'll do as a doctor, because it really is. There are a few things that you can do that are truly life-changing to patients, and I feel fortunate to do what I do, because it truly is life-changing. Patients tell me that all the time, and it never gets old. Like, it really is just a cool feeling to be able to help somebody out like that. So shoulder arthritis is actually very common. It's just not. It's not to the level of knee and hip arthritis, because most people don't weight bear on their shoulders, right? So you can tolerate fairly advanced arthritis in your shoulder for a long time. So the numbers are much lower than hip or knee replacements, but they are on the rise. It's the fastest growing segment of joint replacement, primarily because we've solved a long-standing problem in the last 20 years or so of patients that had rotator cuff tears that developed arthritis. And we didn't really have a solution for that before about 20 years ago. So there's two types of shoulder replacements, and my hip and knee colleagues like to joke that shoulder's not a real joint because you can put it in backwards. But there's something called a primary total shoulder arthroplasty, or just a total shoulder arthroplasty, and that involves literally just replacing the ball and socket of the shoulder with metal and plastic and a short stem. That relies on your rotator cuff. You have to have a completely normal rotator cuff for that replacement to work. We talked earlier that the shoulder is kind of like a golf ball on a small tee. So it's a soft tissue balancing procedure as much as it is a joint replacement, interestingly enough. For patients that had arthritis and they had rotator cuff tears, which is extremely common, to the point of about 75% when you get into your 60s and 70s, late 60s and 70s, those patients didn't really have an option. You can't put that replacement in, because what would happen is it would just be unstable. So it would either dislocate, or they wouldn't have very good function. It may give them pain relief, but it did not give them very good function. So a much smarter physician than me figured this out. French surgeon named Gramont figured out what's called the reverse shoulder replacement. So essentially, it's just like what it sounds like. You flip the ball in the socket in the shoulder. So you put the ball where the socket is, and then you have the socket where the humerus side is. So what that does is, it's brilliant. It converts your shoulder to a semi-constrained joint, and you use the biomechanics of the ball and socket to replace your rotator cuff. I think it's a real joint, because it's the only joint in the body that replaces a soft tissue problem. So what it essentially does is it utilizes your deltoid muscle, which is the cap on the end of your shoulder. When it contracts and you don't have a rotator cuff, your arm drives straight up. So if you've ever seen somebody that struggles to get their arm up, they may lift like this.
Yes.
Remember John McCain. Now, he had a little bit different problem, but I think it was pretty obvious to most people when he would go to shake hands or hi, he had very limited motion. So his was a different problem. I think that was due to his time in Vietnam as a POW. I think he had some fractures there, but the functional mechanical way he moved his arm was equivalent. Like, he would just have to kind of raise like this. People hike their shoulder up, and a lot of them can fake it pretty well until you examine them in clinic. But what it does is, when your deltoid lifts and you don't have a rotator cuff, it drives your shoulder straight up, because there's no force pulling it this way. So the ball can't rotate on the socket. But when you use the reverse, you have a ball here and the socket here, right? So now your deltoid on the humerus side lifts, and now you've got a round ball to rotate and basically do the work of your rotator cuff. So that was approved in the United States in the early 2000s. I want to say around 2003. My mentor in Houston, Brad Edwards, who is also LSU grad, he did his training in France, and they had the reverse there a few years before. So he hit it perfect when he came here. He became very well known because he was one of the few people that was really well trained on the reverse shoulder replacement, in addition to some other things. So I learned under him, and really and truly, I find that one of the most fascinating parts of my practice, because especially with the reverse replacement, it's a biomechanical problem. And everybody's a little bit different. More than any other part of my practice, I spend a lot of time figuring out the mechanics of where to put things and kind of rebuild their shoulder, and I find it fascinating. And obviously, I learn more and more as I do more and more of them, and it's a truly satisfying thing to do, to be able to help somebody that can't lift their arm, can't can't really sleep at night because they're in so much pain, and immediately they feel better.
Are there limitations that a patient might have? I don't just mean immediately post-op,
Yeah.
but in life, long term.
Yeah.
Yes.
So, I see a fair number of young people with arthritis. I mean, even my age with severe arthritis, and that's a much more challenging problem to treat because there are limitations with it. With the plastic socket we use on the regular shoulder replacement, it has a shelf life because plastic and bone only lasts so long before it starts loosening. There are definitely limitations when I put those in on somebody that likes to lift weights. There are other options we can do, like a partial replacement and those kind of things, to allow them to maybe continue at the level they want to. With a reverse replacement, sure, there are limitations, but look, I have patients that go out in the yard, do their yard work. I have patients that I'm sure lift weights with them and do a lot of things. I tell my favorite line to patients is, it's like tires on a car. The longer you drive, the more you use that shoulder, the faster it may wear out. I don't know when that wear out point is, but the more you use it, the more likely you may need to have a revision.
Your professional journey has been fascinating. All the different things that you've done. Do you think about what orthopedics, in particular with shoulders and elbows, may look like in 5 years or 10 years
Sure.
or 20 years?
Absolutely.
What do you think is the direction and advancements that are exciting?
So I think so for shoulders in general, I think, well, I mentioned it a second ago. There's a giant unsolved problem on the socket side of shoulder replacements, of a traditional shoulder replacement. The reverse shoulder replacement, again, is a little bit different because you're putting a metal ball there and you use screws, and so that really does last a long time. The bone grows into it and it's very solid. The main limitation of shoulder replacement at this time is plastic socket directly on bone. We have not figured out a way to have a metal backing there. The shear forces that a shoulder sees are just that we haven't figured it out. There's been a couple of European companies that have attempted it. There's one that just came out with it again. Just not great data enough for me to feel comfortable doing it yet. So that's a giant unsolved problem. And I'm 48. I can't imagine having a shoulder arthritis and needing a replacement and being told, look, the best I have for you right now is we can put a partial replacement, so we can put a smooth ball in, but I have to just kind of reshape your socket and leave you with bone. So you can imagine that metal, or whatever substance we use for the metal for the ball rubbing on bone, is not ideal when you could have plastic. But again, if I put a total shoulder replacement in a 48-year-old, they're going to wear it out within a few years. The data is clear on that. I mean, the revision rate within 5 to 10 years is insanely high. So that's a big unsolved problem that I think we need to work on as shoulder specialists. I think from a certainly the shoulder's part of it, but a more generic orthopedics is biologics. I don't think we have a handle fully on what specifically works well and what doesn't. But I think, the trend is to definitely utilize that a lot more than we do currently. I think there are some exciting aspects of it. And one of the fortunate things I've been able to experience at LSU is really having anecdotal, admittedly, evidence. But, we have the ability to use those sort of things on the athletes there, just because of the financial support of the school and everything else, where I don't necessarily have that same opportunity in practice because it's cash pay and expensive. And we've been able to see what kind of benefits some high level athletes can get. So I think that's another big topic that I think will continue to be a much larger part of our practice as I get towards the end of my career. And then from shoulder replacement, the other thing I think advancement wise for us will be robotic. The hip and knee guys have their robots. I keep getting promised that by that company that shoulder's next. So I actually use their implants exclusively. So I'm excited. I've kind of made it onto the, I don't know, whatever it is, the education consultant or something. Anyway, I get to try out their newer stuff. So the newest thing we have that I've been able to use is I use virtual reality glasses. So I can overlay my 3D plan in surgery, but it's still not quite the same as a robot. I still have to manually do it. But that's where we are with shoulders. We're probably about 5 to 10 years behind the hip and knee guys. They get all the fancy toys. So
VR surgery sounds pretty cool.
it's neat. I mean, it's taken some getting used to, but it's been a nice addition.
Are you wearing VR goggles?
I'm wearing VR goggles in surgery. Yeah,
Wow.
yeah, and it looks funny to everybody else. I haven't set it up where everybody else in the OR can see what I'm seeing, because it just looks like I remember the Pokemon game a few years ago. People were walking around with their phone. I think that's what I look like. But it really is. For me, it's been a very nice addition. I've been fortunate because with the company I work with, it's really it's allowed me to kind of beta test some of these newer things, because I think when I started using them, I don't know what the number is now, but I was one of the first 50 to use it, and I was the first one in the state to be able to use it. So that's a cool, it's just a cool thing to be able to be a part of that. And it really it's not just that, a lot of them joke it's not my toy, but I mean, it really does help me. It makes a big difference. I literally can overlay my 3D image of the humerus where I'm working. It helps me be more accurate with my cuts and all those kind of things, because where that helps is long term and longevity of that implant. If I make it more precise, like I want it, then I think it will last longer and be more beneficial for the patient long term.
And we are sticking with orthopedics, right?
Yeah,
we're not going back to it for another residency.
My wife and I have been married 21 years. Be 22 in April, and she loves me, but I don't think she could do another residency. I've joked about it a couple of times, but that was an interesting convo. I have the method to do it if anybody wants to do it. You just have to make it a joke suggestion first, and then, but what if I'm serious? And then kind of go from there. But look, I'm fortunate. She actually works with me. She's one of my teammates in clinic. She's an RN by training, so it's been great. It's neat because I work long hours, and it allows us to see each other still. And so when we're off, we can concentrate on the kids. So.
Time well spent, no doubt.
Yeah, for sure.
This has been as well. We appreciate your time today.
Yeah, thank you so much. I appreciate you, Matt.